taking on from where Kumar has left, like I said in the morning in two of my addresses, that Boris Mulligan has actually done us a great favor by thinking of the polypropylene strand as a pupil expansion device. That's really disruptive innovation, and he must be given credit for what he has done, because all the pupil expansion devices post-2007 have been based on that concept, and nobody can take that away from him. So, getting on to my device, the Bhattacharjee rings can expand the pupil with a single 20-gauge incision, a 0.9 incision, which no device in the history of ophthalmology has been able to achieve. It has notches and flanges and does not have any helical loops or scrolls. I have a financial interest in the form of pending patents in the US, PCT, and India. Iris hooks and retractors have come a long way. They still hold good, but they have the possibility of causing a sphincter tear, and which could cause a lot of glare and disfigured pupil. We have had pupil expansion rings, but they really didn't stand the test of time. Now, the Mulligan ring came and changed the equation, and they were highly effective in IFIS and other situations. But does the Mulligan ring meet all our present needs? Femtosecond laser-assisted cataract surgery. Now, we have scientific evidence to suggest that femtolaser corneal incision is superior to the keratoderm incision in terms of reduced endothelial gaping or misalignment, descending membrane detachment, posterior wound retraction. So if we could use a single 20-gauge side port incision to expand the pupil, we will not be denying the patient a truly triplanar femtosecond laser corneal incision. So the keratoderm incision in a femto case is probably a compromise. This is a study by Konrad Hengerer et al., which shows that a 2.75 mm incision for a Mulligan ring could probably be increasing the risk of endophthalmitis. Now, this is by Robert Lawless et al., and they say that clearly that the laser is a clean but not sterile procedure. So there exists an unquantifiable risk of infection. So a ring through a smaller incision would be definitely better on at least these three counts: superior corneal incisions, reduced risk of infection, and reduced risk of anterior chamber shallowing during docking. Bimanual and coaxial MICS use incisions smaller than 2 millimeters, and unfortunately the Mulligan ring requires at least a 2.2, and those who have used it will know that it really doesn't go through a 2.2, so you need something like 2.5 or 2.7. So they can't be used for bimanual procedures. Shallow anterior chambers, it's a very tricky situation. It's a strand thickness and the vertical profile at the corners. Now, if you realize the corners lie at the mid-peripheral anterior chamber, now that is where the anterior chamber is actually a lot shallower. Okay, go ahead. Okay, yeah. So, at the mid-peripheral anterior chamber is actually half the depth of the central anterior chamber. So, a device which has a thinner profile would be a lot safer in these situations. So, the Bhattacharjee rings have a 0.1 mm profile made of 5-0 nylon, extremely flexible with a slim joint. The hexagon is equally thin and flexible. You can use the notches straighten as they pass through a 20-gauge incision, and the leading flange is tucked with a Kuglen hook or with a forceps. We are designing a specially tailored forceps, or we could use a 23-gauge forceps for a unimanual tucking of the flanges, or a bimanual tucking could be performed with a 23-gauge forceps in one hand and the iris hook in the other. And this is a bimanual MICS in progress, and this is a wound-assisted IOL implantation. And you see, the ring does not really come in the way of any of the instruments. This is a fairly hard cataract being done. This is one of the earlier surgeries, and there as part of the study, we were measuring the size of the pupil. Removal, hold a flange, disengage 2 notches on either side, and just drag the device out, and it literally walks out. As simple as that, and we have a round pupil at the end of the surgery. These are the results. With the square device, we had a round pupil at day 7. With the hexagon, we had similar results. This was very rewarding. This patient had a blind eye, other eye, and angle closure glaucoma. And this eye had a peripheral eye 20 years back. The anterior chamber depth centrally was 1.72 millimeters. We used the hexagonal device, and on post-op day 7, we had unaided 6/9 vision. This was truly rewarding. I had a bit of my glory too. We had the best paper award at the ASCRS, and then I managed to publish in the JCRS, and fortunately it's the most read paper in the last year. For the better part of last year, it was the most read paper. And what we added was that it could be used for bimanual or coaxial MICS and femtophaco. It's been used worldwide by a few surgeons. Back home over here, Arup Bhaumik has been using it. Sri Ganesh and Dr. Kasu Prasad Reddy have used it. We are having short clinical trials. Professor Bukha Dik and Kyunchia, Shiraz Daya, there are a few others who've used. This is part of the live surgery that I did at Jaipur 1 month back. This is a 2.2 incision, you'll see, allows the device to go in all the way in the first pass itself, so that you don't have too much of instrument swapping, and then we go ahead and tuck that leading flange with a 23 gauge forceps. This is entirely done on a forceps. I didn't use Kugler hook because forceps gives us much more control. And this is the second flange going in under the pupil margin. And there, and that's the last flange. We are all quite used to these microsurgical instruments these days, so this should not be a problem when we use this for the Bhattacharjee ring. And removal, as I said, you hold one flange, disengage the two adjacent notches, and the trailing notches actually just straighten on their own. And I find it easier to remove the device through the 20 gauge side port. A few interesting cases. This was a rigid pupil. So instead of pupil expanding, the ring expanding the pupil actually constricted the ring. So we just used 2 Kugler hooks and expanded the pupil and got a more squarish shape. And this was talked about. And this is the hexagon device being used over here. And sorry for the video quality over there. And this is the IOL implantation. I was really shaking doing this surgery because this patient was one-eyed. I had an ethical committee clearance for this, and we went ahead and we were successful. This is an interesting case. This is adenocarcinoma with a small pupil with hard cataract. Pupils stuck to the cornea, and you can see it's mature hard cataract. The central anterior chamber depth is 1 millimeter. The mid-peripheral is 1.5. So it's a lopsided situation. So I was in a fix what kind of pupil expansion device to use. So a Malyugin ring would probably get stuck in the scar or touch the epithelium. That would cause a lot of damage. So I thought we would use my device, but the restricted anterior chamber was a problem. So I went only halfway with this insertion, with Helon over there for the leading flange, and then nudged that leading flange into that space over there, and there we had this device in there. And as we tucked that leading flange under the pupil margin, notches engage the pupil margin, and now goes the third flange. The rexus size was restricted by the size of the pupillary device, but it was a fairly good size. As you can see, 6 millimeters pupil, and the capsular rexus was about 5 millimeters. This was a fairly hard cataract, and with any pupil expansion device inside the eye, we would like to make these fragments as small as possible so that we do not displace the device and cause problems. So we had to chop it into as many small fragments as possible, and then go ahead and remove these fragments. You can have evidence of iris over there, the iris prolapsing. We let go for that for the time being, and we first decided to remove the ring, and that's the flange being held and the 2 notches on either side being disengaged and the device being pulled out. And these are very sturdy devices that maintain their integrity even after so much of handling. And that's the pupil, I think, quite rewarding at day 7, as round as you probably get with a clear cornea. So it's not the strongest of the species which survive, nor the most intelligent. It's the ones which are most responsive to change, and change is the only constant. Thank you very much for your kind attention.